I am Dr. Denis Losik, cardiologist with huge experience in managing chronic cardiovascular patients, especially with implantable devices and like ICD or pacemaker. And last 5 years, I deep dive into the digital transformation and AI implementation into clinical practice. And today with me are two experienced clinicians from UAE and cardiometabolic patient will be deeply engaged in our discussion. Let me introduce Dr. Samer. He is a cardiologist and AI enthusiast from Abu Dhabi. He has a lot of publication about AI in medicine and huge experience in real clinical practice in Cleveland Clinic, Abu Dhabi. And Dr. Rami, he is a family physician with extensive experience in digital health transformation in telemedicine, and also very like to use AI in his daily practice. And our patient, Hani, who spent more than 14 years in oil and gas company in GC region, and right now, he is a co-founder and chief operating officer of Proteum Technologies. It's a company about advancing sustainability, renewable energy, and hydrogen solutions. I met Hani during the conference regarding intellectual property, and when we talking, he said that he is not just the co-founder of the company and chief operating officer. He is also a cardiometabolic patient with experience or more than 20 years and of diabetes. Hani, I want to start with you regarding like your patient experience. And I show your summary regarding your case scenario. Okay. Did you see my screen?
Yes.
Yes, I can see.
Yeah. Okay. Please tell me your story from when you became like a cardiovascular patients in 2024. How it's happened? How you understand that you have a problem with coronary disease?
Well, first of all, thank you, Dr. Dennis, for the invitation. And thank you, Dr. Rami and Dr. Samir. The history started in 2024. Actually, it was by coincidence. I just wanted to check on my health, like a regular check. And the doctor, he did the stress test for me. And he said, okay, let's see if there is any issue. And then he was not happy with the results. So he asked me to do the cardiography, I think, the MRI, the colorful, with the contrast. And that where it showed I had two blockage. So I asked him that if I can postpone the PCI for like another week because I had to travel. So he asked me to be on statin medication and to take aspirin. And everything was normal. I never had any symptoms. I never felt anything. I never expected that. I was even shocked that I'm still less than 50. I'm still in the 40s, and how this could happen.
Okay.
And I was there.
Yeah, interesting. Let me ask the audience regarding the two questions for cardiometabolic patient management. You can see on the screen the survey, and you have like 1 minute to answer. For patients with severe multivessel coronary artery disease and diabetes, type 2 diabetes, which revascularization strategy would you choose as the primary approach when you find the significant coronary artery stenosis? Is it a PCI or CABG or balloon angioplasty, or maybe the conservative treatment therapy. Dr. Summer, what do you think? What is the perfect strategy
So there
according to
is
the
no
clinical
perfect
guidelines?
strategy. Yeah, so there's no perfect strategy, but for patient, we need to look at three components, obviously. The symptoms of the patient, the past experience with restenosis, issues, caliber of the vessel, size of the vessel, proximal, distal, it's technical, so I won't go over it. Second is overall, especially in diabetic, especially the heart is a little bit weak. And third, also involve the patient in the decision making. So I always say we don't do things on the patient. We don't do things for the patient. We do things with the patient. But per the guideline, probably in general, other things being under control, first line would be CABG or coronary artery bypass surgery.
Okay, okay. Yeah, it's like right now we like have a 50-50 like PCI or CABG, but yeah, it's I agree with you. It's uh, shared decision with patients as well. And to come back to the honey, how was made the decision regarding PCI in your case?
I didn't have a lot of options actually. We planned to do the PCI on Wednesday, but I couldn't believe him. So, like after 1 week, he said to go travel and come back and make it immediately. I cannot wait for you. And I was like, come on, you have to be serious. Like, it's not so urgent. I had to go and see another two doctors. And the two doctors, they said, yeah, he's a little bit maybe exaggerating. And on Tuesday, I had a heart attack. And when I went to the work on Wednesday to activate my to check the status of my health insurance, I couldn't. They took me in ambulance all the way to the hospital.
Okay. And during this procedure, what is your, do you remember like how aware you was regarding the target points of LDLC? Of course, you have a huge experience in diabetes and you know all these things, but regarding like another metabolic problem, like you was aware of it or you just starting to manage these parameters as well?
No, I start learning.
Okay, okay. Okay, and after the procedure, uh, after like 6 months, as I know, you go to the appointment and make a stress test, and it was negative, and you have no issue with any angina pectoris during this period after the PCI. Yes?
That's true. And even the doctor, he told me like he was like, thumbs up, you're good, nothing to worry about. The only thing that you need to control your diabetes and your weight, and that's
Okay.
it.
And how you control and what you use for control the LDLC and glucose, blood glucose during this period?
This period, I was on the metformin and for Zega and mainly those two. And my blood sugar was not under control. I had to go to a doctor to ask them for the help, and they asked me to start using long-lasting insulin overnight so I can reduce the baseline. Uh, my interpretation, my understanding, my observation was is the high statin medication that I was taking. It was making my blood sugar out of control. I was taking 80 every day and night, and over like when it was out of control, like when it was not in the range, the doctor even added the other medication too. Uh, so I was struggling to get my blood sugar in place.
Okay, and after it, you have unstable angina, and you go to the repeat coronary angiography, and this show significant restenosis. Yes.
That is true. After I came back, it was in Jordan. It was after Ramadan. I came here in UAE, and beginning of May, I start feeling like being exhausted and tired every time I walk or I put some effort. And till the moment that I start, like if I walk for 100 meters, I feel like the full symptoms. I get all the chest pain all the way to my jaw, and I asked my wife to take me to the emergency. I said, like, I cannot keep quiet on this. And when they took me to the hospital, before that, one day, I was in the same day, for no reason. I had to throw up for no reason. So I didn't understand what the reason was. For I didn't know what was the why I threw it up. But then when I went to the doctor, the hospital, to the emergency in Al Qasimi Hospital, all the enzymes were in place, good. The CGI, what's called the CGI, or the graphic for
Okay.
the it was perfect. So the doctor said, like, just because of your description, just because of what you're telling me, I'm gonna keep you. But all the all the indicators that I have on my ground, there is nothing. You're normal. But just
Okay.
because of your history and your description, I will keep you in hospital.
Okay. And also, like during the admission, your diabetes was not under control. It was like HbA 112%, and LDL-C was 2.3, despite the high intensity dosage of atorvastatin. Yeah. And after CABG, like how you're feeling, it's became better, and how you manage your target points right now.
Right now, I am more aggressive towards my diabetes. I am using the continuous glucose monitoring systems from like the Freestyle Libre, and just to make sure that my blood sugar is on target. I reduced my statin. Right now, I'm taking 20 instead of 80, and that helps a lot. Of course, diet, it is main thing. The only thing that I couldn't do it, which is the activity, the
Okay.
sport. Yeah, like I need to put myself back into habit.
Okay. Uh, Thank you very much. And what do you think, like, do you use ChatGPT or other LLMs to ask the questions regarding symptoms, and regarding like your uh, health?
Definitely, like on a daily basis, almost, especially like when I was in Jordan, the only thing that indicated that I needed a medical assistant, it was that I put all the symptoms together. I didn't know what was wrong with me, and it was a clear indication that I am going through a heart attack. So I called my relatives. They took me to the hospital immediately. During the surgery too, I had to go through a lot of conversation with ChatGPT. That am I gonna live or not? So definitely, it was my first source of information.
Interesting. And what do you think about healthcare, like insurance or healthcare provider? What do you think about the role of manage your chronic disease, if they like call you, or using the telemedicine to check to navigate you through these target points? Is it helpful, or how it works from like your patient experience?
Uh, when it comes to diabetes, I think I know most of it. I've been 20 years with this dilemma, and every time the doctors are almost repeating every single thing, so I know them by heart. I don't see anymore the directions from the doctors it's effective anymore. The only thing sometime is just when you have an appointment with doctor and doctor reminds you of what you need to do, is just like a point to set you back in line. So you deviate and then it sets you back online. That is the only advantage for me at this point when I go to dietitians or I go to diabetes. Most of the medications now is like very well known, and I know them and I know how to take them. When my diabetes is out of control, I go to the pharmacy. I was like, give me 30/70 insulin, and I start injecting myself. But to put myself on track, I go to doctor if my
Okay,
habits out of control.
okay, okay, I got it. Okay, thank you very much. I think
Welcome. Welcome.
it's a good time to jump to the clinician part and ask the question regarding useful case of AI in clinical practice. What do you think, Dr. Summer? Do you use chat GPT or Claude during your clinical practice, and how it useful, and maybe other cases of AI in the cardiology?
So it's not just about what I use, it's about also the potential of use. So there are three areas where clearly AI is helpful. And before we get into this, to oversimplify this for our delegates, in case you're not into this, so think that you and I are gonna bake a cake. So the ingredients are the data. And currently we have millions and trillions and zillions of data, but we don't use in decision making. So that is the material. The recipe, how to bake, how you want chocolate cake, strawberry cake, is the algorithm. And then the outcome is the cake. Allow me, Hani, to talk about cakes in front of you, but you can eat only a little bit. So with that in mind, there are many, many things that can be done, not only with AI, et cetera, et cetera. There are many other aspects, blockchain, metaverse, et cetera. But there are three that I think we should keep in mind. Number one, the concept of chatbot, which is simply from the beginning, even before the patient comes in, all the way till you have the discharge material to give the patient. And even in telemedicine, my colleague Dr. Rami can talk about this. Markedly underused, markedly underused. Second thing, and I think the most important, clinical support in decision making using the decision making from the data. So the data is being collected and we make decisions based on the guideline. And I want just the team and my colleagues to hear this. So I was selected from a 1,200 group in Washington, D.C. on the ATP3 guidelines, the old guidelines for cholesterol. And in the meeting, around 1,200 people were there. Someone asked, how many of you use the Framingham risk score? Guess how many raised their hands? Either 4 or 5. These are the selected group. And they said, because it's too complicated. The third important role of AI, and there are many, is obviously what you brought up, the LLM, and there are many of them. We use them typically for us in selective cases when something is unusual, etc. Whatever is the methodology, I strongly feel, not because this is my area of research, but truly, I strongly feel that physicians and patients who do not understand that AI can add value are missing on a lot. But if I want to focus on anything, it's getting the electronic medical record, going through a decision support system, and then giving some recommendations that the physician may or may not take.
Okay. Rami, from your experience, what do you think about the regulation part of using AI? Because we have a lot of hallucination and
Yes.
not good answers from the chatbots. And what your thoughts on it?
Yes. No, first of all, thank you for having me. And this is a very interesting, it's a very interesting case. And I think it's obvious to everyone who's not technical that it's a complex case. And as Dr. Samer, eloquently put it, everything that is complex needs to be simplified to have clear decision making, and that comes down to the data. So and this is where the value that of something like artificial intelligence or machine learning algorithms can come in. They can take all that data and they can simplify it, and they can help with the decision making and because it's obvious from this case, for example, that many things were missed because of the interaction between the two big medical conditions, the cardiometabolic, the cardiovascular, and obviously the diabetes. In translation, and maybe that's also a temporal aspect of the patient's time or even the doctor's time, some things were missed. And this is what we call in practice, this is a classical case of reactive care. So what we would like to focus on, and this is where tools like digital and artificial intelligence can help with, is proactive care, is to avoid all that unnecessary misery that Hani went through. So alhamdulillah, he's much better now. But a lot of things could have been avoided if we efficiently use the tools that we had. Now, in terms of obviously, if we go down, dive deeper into what we have at our disposal. I mean, Hani spoke about large language models and using ChatGPT. Obviously, we still say this even in digital, even though we've been working in digital for decades now, that it's still it's at its infancy phase. I would call it now as a toddler that's trying to walk or trying to run, but it's still not there yet. And so we need to be very careful in terms of using these tools. And that's why, for example, my work is to focus on the governance of these tools, governance of artificial intelligence, governance of digital health tools. And governance doesn't only mean regulation, because you spoke about regulation. Regulation has a big component, obviously, to play in this, but governance is preferably a bottom-up approach, where it comes from the user, the end user, which could be the physician or the clinician or the patient, and then to the organization, or to the vendor, and then the organization, and then all the way to the regulation. So yes, these tools, as you put it, they suffer from some flaws that are being actively addressed. Hallucination is one of it, and hallucination is actually a fundamental feature of AI. It's not a flaw. It's a feature of how these models work. But the way to mitigate it is what Dr. Sama referred to, is the data, the veracity of the data, the fidelity of the data, and the volume of the data, and the diversity of the data. So these are things that are being actively, obviously, people are trying to address it on the vendor level, on the provider level. But it comes down to all the stakeholders. All these stakeholders need to be aware of the risks and of the risks that come with using these tools. And obviously, one of the main things that we always advocate for is having a human in the loop. So obviously, at the end, there needs to be a human who makes the decision, whether it's the physician or whether it's the patient, even for themselves.
Yes, sure. And regarding the clinical decision support, Dr. Summer and you mentioned, it's a clinical decision support to use the real world data. Who you mentioned that clinicians should make this decision, but from the source of data, not just like electronic medical records, from the knowledge based, how we can to be aware about source of data. It's a international clinical guidelines. Some companies go through the publication level. What is the level of awareness of clinical decision support should be? What do you think about it?
Maybe Dr.
You're
Sama.
asking me? Okay. So, not to overcomplicate this, basically, we have guidelines, and the guidelines usually with minimal bias are being put and updated. Some of them took a lot of time, like the American guideline for dyslipidemia that just came up a few weeks ago. It took 10 years. Others every 2-3 years. Number one, which guidelines to rely on and how would depend on the location, a decision. For example, in our institution, we made a significant decision in UAE that the European may be a little bit closer to us and more simplified. It doesn't matter. But as long as we did it The number one problem in this is that people don't follow the guidelines already. So the guidelines before were followed, implemented 30% at best, and the control was low. Now we make the guidelines even more strict. Typically, I don't remember a guideline that became less stringent, become more stringent. So I met in UAE a few years ago the president of one of the medical societies, and I said, we're running with the guideline and evidence-based, and it's all okay. But I didn't see anything except a small paragraph on how to implement them. And he said, wow, this is the responsibility of the doctor and the patient. That's why doctors are paid for it. I politely disagreed and showed him that part of this is based on the concern of the risk assessment and the idea of personalized medicine, like for my colleague, Mr. Hani. This needs to be very clarified and goals need to be set. Because if the goals are set, there is at least a better chance for the patient and the physician to work together. So to answer this in a very simplified way, decisions are made through the governments. And I love what Dr. Rami said. It's not only control and regulation, but it's also promotion of what's right. And also whether we hallucinate, the system hallucinate, we all hallucinate in one way or another by not following the guidelines. And then the second component is to have it built in, and it's only AI supported AI. So it's not replacing physician, it is augmenting physician. So the word artificial intelligence would soon disappear. There is nothing called artificial intelligence. There is some support, augmented intelligence using data that's appropriately collected. And three is from the beginning, if I'm going to use chocolate that's rotten and the flour is bad and I don't have the right equipment, then obviously nobody is going to eat the cake and it's going to be rotten. So the usual garbage in, garbage out is multiplied 1 trillion times with the AI and the concept. The idea behind this clinically, so not to lose anyone, is I need support. If you look at the dyslipidemia guideline, which I will discuss briefly later on, is nobody is going to keep up with CT calcium score 0, but had a history of diabetes. Diabetes was non-insulin dependent, but for so many years. The eyes were slightly affected, but nobody can keep up with this. So this will be markedly simplified, recommended, and introduced. And we only spoke about this. There are a million areas to be discussed, which I will discuss later on.
Okay.
I don't want to over talk about this. Okay.
Okay. I think it's a good time to jump to the presentation, how we can use real world data to analyze the electronic health records information and use it as actionable to change from reactive to proactive. Dr.
Yes.
Summer, please.
Just please
Floor
confirm
is
that.
yours.
So first, let's focus on the current status of healthcare. Healthcare is extremely reactive, rarely ever proactive. And this is not because the patient do not listen to us or the doctors are not good. It's because the system itself, from a system thinking standpoint, was built in such a way that it is sick care, not healthcare. So the concept behind this, even from insurance company standpoint, even when you build the system, even for fee of service, is we want patient to come unintentionally and they are sick. And very importantly, it's reliable? No. It's advanced but not reliable. It means you want to have surgery at night, not as good as in the morning. With those things in mind, we need to create the need, this gap. The second concept, before we drown into details, is that AI did not, as my colleague Rami said, did not really penetrate in healthcare as much as we think it does. We just talk about it. But if you look at the implementation and success stories of implementation of AI power, it's extremely limited. I'm going to make a case that ethical medicine should be AI powered. If done properly, if it is done ethically, if privacy is maintained, if appropriate governance is created, and if we understand that all of us someday will be patient and we need to act quickly, not take it easy. With that in mind, I'll move to this. So the concept behind this, we don't want to drown on details and the slide and what does it show. But if you think about it, when we had the concept of what electrocardiography is, which is one of the most fascinating concepts on earth. We moved from this is a technology, it's an era of awareness, we need to do it, and then only cardiologists can read an electrocardiogram. And then obviously the ECG moved, and more people became interested in this and are able to read it, emergency room physician, primary care, etc. Let's move on. Currently, these three journals, among others, and incidentally, not for show off, but just to tell you, I'm on the reviewer of all of these journals. I'm a reviewer of it. You need to understand that all of us at this time need to think not only about cardiovascular care, which is my interest, but about any care that without injecting artificial intelligence, literally injecting into medicine and creating a performance improvement plan that we're going to do it, two things are going to happen. Patient would suffer and healthcare will suffer and physicians will suffer. Because unless we are becoming more and more AI, not necessarily savvy, but at least supportive, this is going to make us look like we're really all the way in the bag and we're not really moving in the right direction. Let's take the example of chronic disease management. So you look at this, and cardiovascular disease is already leading cause of death, and we hear it. It's almost like, I don't care, I already know it. Accounting for almost 1/3 of all death, followed by cancer. Comorbidities are progressing. We can talk about this in a completely different way. We can talk about this. So I have my ABCDFS. A is awareness. A is aspirin use, B is blood pressure, C is cholesterol and cigarette smoking, D is diabetes, weight, E is exercise, F is healthy food, S is stress and sleep. And you can put it in any format you like. I put it in this format personally in my note in AI model that I use. And this can be really driven with technology if we do two things. Number one, we understand that even at the level of the physician, the decision support that we think is in our mind, the physician doesn't have the time and sometimes the luxury to even define how risky this situation is. For example, for our colleague, his LDL needs to be less than 1.4 millimole per liter, or it's around 55 milligram per deciliter. I may see it, you may see it and say, oh, you're doing well. Your LDL is 2.1. It's much less than before. And, keep on the good job. His blood pressure should be less than 130/80. Oh, you're okay. It's 145/90. You're anxious today. I'm sure you've seen this inertia. 3 is hemoglobin A1C. Oh, we want it less than 7, but in your case, it's 8.1. Hey, you're making progress. It's fine to be encouraging, but we really need to do that based on risk-based. All appropriate management, not in healthcare, in life, is risk-based. Then we go from our remarkably important randomized controlled trial that are typically with strict eligibility, very homogeneous patient, they match, short follow-up or maybe longer follow-up, but as long as, how long could it be, right? Except for some studies that you are aware of, typically it's weeks, months, few years. Definitely high cost, that's for sure. And then typically a small sample, we're taking it, and based on it, we're going way out and generalizing. Versus real world data, which is becoming more and more discussed. And typically it's AI powered through registries, but also through other ways. It's a broad patient population, markedly heterogeneous, but in a good way, because you're looking at different subgroups. Long-term follow-up, we're talking about years and years. Cost efficient, obviously, and scalable, and very large sample size. So if you keep that in mind, by itself conceptually, if you think about it, this is an absolutely different way of thinking, not about research, but about healthcare. Not to complicate this, maybe the slide may not be initially clear. We have the guidelines and we have obviously the recommendation of an institution or an area, but there are so many things that may not be accountable for. I'll even make it more challenging for you and me. Even the guidelines themselves, I brought to your attention that with the very complicated risk-based models, Many people, because of time, because of experience, and also people get tired, feel that I'm absolutely exhausted and I cannot keep up with all of this. An AI agent can very simplistically, and this is real, this is not, in the future, can not only tell me what to do, but I'm sure you heard about the AI models predicting from a simple test many other things which I can discuss later on. The guidelines. We're all for the guidelines. Absolutely, 100%. We should individualize guidelines. We should be careful with guidelines, but we are for guidelines for the most part, at least from very well-known societies. I'd like to focus on the last one, 2026 ACC AHA guidelines. I'll be very brief. You would not believe it how many things are in the risk model. You have literally to sit down and go from one page to another to create a model to understand what is the risk of this patient and where should I go with this patient. And this, while being very, very important, can be extremely complicated, cumbersome, and many times people simply don't do it. AI in cardiovascular disease, real world data. There are many aspects to this in advancing cardiovascular care. We can talk about patient safety, proactive efficacy, equity, very important. In some areas that don't have expertise, we can move this in a very good way and help them. Reliability, which is what I brought up. Advanced but not reliable. But the most important, in addition to the famous financial sustainability, is electronic medical record and the input from it that needs to be used appropriately. I'm not going to go into petabytes and all the numbers. I'm going to just tell you one thing. Very rarely do people use the data appropriately, not in a big hospital, in a small clinic. I remember speaking to a group in a very respectful area in a healthcare setting. And I said, how many of your patients are uncontrolled? This is for my friend Rami and Hani and for you, Dennis. They said 100% of our patients are controlled. Diabetes, 100%. I'm not joking about this. There were like 1,200 people there. I said, how about hypertension? 100%. Wow. That must be, some people went to heaven too soon. I said, how about dyslipidemia? 100%. I said, wow, this is amazing. And they were so happy. I made no other comment till we went to the Q&A session. 25% of patients with dyslipidemia achieve goal, not because of health insurance. Even in Canada, where it's completely covered, even in countries in Europe, even in Far East, across races, religion, gender, same number, 25 to 30%, showing that not only the system is suffering, but the approach needs to be improved. Until we use decision support systems, we're not moving. So obviously, if you want to enable the guideline aligned, reimbursable patient flow from this, we need to have a model. I don't want to really go into this in extensive details. Do as much as you want, pay for performance. You do wherever you want till the system and the way of thinking has changed. And we're supporting clinicians. In the European Foundation of Quality Management, just a quick break, I love what they talk about. They said, you want result? You need to have enabler. Al-Mumakkinat. You need to have enabler to get to where you want to be. Keep on doing whatever you want, it won't happen. This patient, all of us, someone need to have all these things. Dyslipidemia, chronic heart failure, atrial fibrillation, arterial hypertension, CAD, diabetes, chronic. Are you really serious? Are you serious that physicians are going to see 20, 30, 40 patients and they are going to follow all these guidelines and be updated? Cardiology is easy. Ask Dr. Rami about primary care, where they see every walk of life, every disease, every entity, even in family medicine, from age of kids all the way to elderly. Clearly, we need to change this to implement appropriate chronic disease care management. So with all the input that we have, huge number of data, not only demographics, diagnosis, lab, discharge summaries, ECG reports, imaging, cardiovascular risk. And remember, the imaging can be looking at how it was read, but you can also have the images themselves being co-read. To the output data, the patient needs to be analyzed appropriately. إذا عرف السبب بطل العجب. If you know what's going on with the patient, then you will be able to clearly define the patient. When I hear the patient is not adherent or not compliant, immediately I get upset. Why? Because the non-compliance, in my opinion, is 80% my mistake and 20% area of improvement for the patient. We need to simplify for the physician and for the patient in a healthcare system appropriately so we can move on. So this is a study. I'll go quickly over it for the interest of time. Look at this. If you look at the patients who need to be on anticoagulant, antiarrhythmic agents, antihypertensive patients with good percentage, only 18%, not even 20, received all three types of therapy in accordance with current guidelines. And typically, as the guidelines become harder, guess what happened? It becomes even worse. This is even a follow. Same thing on the guideline. But if we involve a clinical support decision system, then clearly it makes a difference. So this is not theory. I will not read these slides for you. They are self-explanatory. But I want us to understand, for me and you, as healthcare providers, as administrators, as nurses, as physicians, as patients, this is the way, at least to implement the guidelines, let alone to improve control. And with that in mind, look at this, another one. Looking at the study design, which I will not take too much time on, but if you have a clinician supported by CDSS, really a clinical decision support system that is being updated with the guideline, that the governance that Dr. Rami spoke about, that Hani expected from all of us as patients, as doctors, then there will be a significant improvement. Not only I care about the p-value, I care about the absolute benefit. And you're talking about critical, but I'm not talking about something minor. I'm talking about antithrombotic, clots or bleeding. I'm talking about hypertension. I'm talking about cholesterol. I'm talking about diabetes. Huge. Now look at the lipid look, that everybody think they are doing an amazing job on. Again, minimal control, remarkable improvement if you use an appropriate CDSS. Obviously, if the system itself doesn't have the guidelines you believe in, that's your problem and my problem. If the system itself does not embrace a risk assessment tool, looking at all the personalized data, pulling the data in a timely way within seconds, proposing, recommending the next steps, then that's obviously the mistake of the system. And again, another concept regarding this. And please remember, you cannot implement what you're not even sure about. For example, if I tell a patient that your LDL is okay to be 3.0 or 116 milligram per deciliter, when it's supposed to be 1.4 millimole per liter, or 50, at the beginning, I was supposed to go to Al Ain, I went to Dubai. I took the wrong direction. So from the beginning, we need to set the goals before we move on. And the clinical support decision system is very helpful. That becomes even more important if I cannot keep up with all the guidelines. I find difficulties with many specialties like primary care. So if this is important for cardiologists, this is 10 times important for people who see even a more variety, a larger variety of patients, as you can tell. So when we look at real world data, and we look at how we can filter this information and look at it, AI can become a predictor. AI can become a risk assessor. AI can become helping us in clinical support decision making. And most importantly, it can improve efficiency. And this is not an advertisement. This is from the bottom of my heart and my ethics. This is the way to proceed so you and I can be more efficient and spend more time with the patient, smiling at them and doing what we need to do. Look at this. Number of patients with chronic heart disease without a visit to GP or cardiologist decreased among analyzed cohorts. Imagine. So you're talking about after digital twin technology implementation. What is digital twin? Basically, I, myself, Dennis or Rami are going to put my data from the record, and by asking me questions, then I create a digital model of me, like almost myself, but digitally. They can even experiment on how much if I give Samer rosuvastatin 10 milligram versus 20 milligram, how much would they benefit? Would there be a slight increased risk in diabetes? No, he doesn't have family history of diabetes. His hemoglobin A1C is 4.8. Okay, but in his case, maybe he has a family history of heart disease. So it gets to be all implemented. 28% of patients with CHD, 61% and 17%. So you're talking about simple tools that can take us, whether it's through the clinical decision support system or whether to implement something more we call digital twin technology, which sounds like wow. It's not wow at all. It's very feasible, very doable, I assure you, and we use it even in the ICU. We're transforming healthcare. And very importantly, if you look at this slide and see what we're talking about, share of patient achieve blood pressure level increased by around 24% in patient with chronic heart disease. It doesn't matter what the disease is. It doesn't matter if it's 24% or 28%. The concept is clear. The method of assessing patient and using the data from electronic medical record can be clearly transformed. And this is what we're talking about. So in general, guideline adherence is a challenge, but it ensures treatment follows current guidelines. Personalizing the data is a huge challenge because all these data cannot be embraced in our mind, and it can easily be embraced by looking at this data through the clinical support decision system. Quality improvement is obvious because if quality is defined as adherence and as following the guidelines, then that's obviously one definition. Error reduction, and this is not about only error whether the appropriate medication was prescribed, but how the follow-up was done. Efficiency is obvious because less time is being spent. And consistency, remember, the enemy of quality is inconsistency and variation. With that in mind, I will stop here and stop sharing my slide. Thank you very much.
Thank you, Dr. Samer, for a good explanation of the using real-world data and AI. Right now, it's a time to demonstrate how we can use real-world data in according the Care&Quality Registry. Right now, if we implement the eMed support system into the clinical workflow. As all of us know that Dubai Health Authority have some project EJADA KPIs when they want to assess the quality of treatment healthcare providers, private and public sector. Also, Dr. Samer, you engage in the JAVDA KPIs in Abu Dhabi. Could you explain some to understand the audience what is it about?
So very briefly, can you hear me?
Yes.
So very briefly, our Abu Dhabi and Dubai and also our Northern Emirates have made a commitment to look at the literature and briefly identify areas of priority from the literature and then see how it models in UAE. And I had the honor of being a founding role in the Jawda KPI in Abu Dhabi, but not in Dubai. And basically, these KPIs are being discussed with the hospitals and the clinicians. They are created through a priority matrix, and then eventually some relationship to pay for performance is being considered in both Emirates and others. And there are many, many things to bring up. They are ballooning now, increasing remarkably, at least in the Emirate of Abu Dhabi, for the intention of looking at the areas of improvement and moving on. One of the challenges is how can this be facilitated and done consistently? That's basically the words on this.
Yes, and in this case, we can really right now can easily implement this solution to use the real world data and prepare the structured data sets for KPI assessment. And for example, it's from EJADA KPIs, cardiometabolic syndrome cohort of patients. and it's patients like Honey with type 2 diabetes, and we can check how many of these patients on the high intensity statin therapy. It's a green bar, but still, if we're looking on these patients, still a lot of patients not on the target point. And with this system, we can easily to check in which medicine this person, and for example, this person with atorvastatin and ezetimibe, it's a good combination, but still it's not on the target point. And we easily can, using a chatbot, we can check the treatment plan according to the clinical guidelines. And it's just in the seconds you can check your prescribed treatment plan, really compare with clinical guidelines, because we using the structured digital profile, we matching this data with clinical guidelines and give the good answer. Also, using this system, we can prepare the your own analytics and KPIs. For example, in the cardiometabolic syndrome, you can easily use the pre-prepared prompts for any KPIs in different cohorts of patients, and checking this through your own questions, and check this. For example, in this case, we have receiving high intensity therapy statins 27%. But please show, sorry, please show me patients receiving and ezetimibe. And these three LDLC in chart. And you can see, like, is it enough to use high intensity statin therapy, or how the patients with a combination of statin and ezetimibe who not achieve the LDLC. You can easily understand and check these patients and prepare the list of patients and make a follow-ups to remind, even like as a Honey, if we remind him to please come to the checkup, and maybe we need to change something in your treatment plan. And I think it will be very useful in the future, but it's available right now. Yeah, Rami, please go ahead.
Yes, I mean, thank you, Dr. Samer, for the amazing presentation. And I think from our perspective as clinicians who've been working in this domain, I think the literature is conclusive. You know, these tools, they're very, very useful. But as Dr. Samer pointed out, maybe it's the adoption, and that's one of the barriers for adopting these tools and using them in day-to-day, let's say, clinical workflows or whatnot. What I like about what you've done here, Dennis, is that you've taken a very familiar user experience and you've customized it for healthcare. And you've customized it for the use in healthcare settings. People are now used to chat with, Chat GPT, Claude, whatever. And I think maybe earlier this year or earlier last year, it was I think it was Satya Nadella. He is the CEO of Microsoft, and he said that obviously you will no longer have custom or bespoke applications. All you'll have is a foundational AI model that talks to the data, and then you can just ask it whatever you want. like you're doing here. You'll just ask it questions about the patient. You're just asking about, for example, in healthcare, for example, you'll just ask it about the patient condition. You'll ask it about correlations that you want to understand, and it could help you understand those correlations and generate maybe even charts. Um, yeah, I see your model is thinking. I think
Yes, yes.
it's
Yeah, because
I think it's digging deep into the data.
yes, yes.
Yeah.
It's like it's synthetic data of 150
Yes.
patients, and also you can you can use the different chatbots, and you
Yes.
can easily dive into the another
Yeah.
chatbot and check, for example, the patients who is with comorbid. It's a comorbid patient, and ask. About suggestion of treatment. Okay, yeah,
There you
ready.
go.
And yeah, we can see the patients with high intensity statin and ezetimibe, and some of the patients close to the target point, but another not on the target point. And we can ask like follow-up suggestion, like show me these patients, or also they recommend to understand that it's these patients may be suitable for more expensive PCSK9 inhibitors to achieve the treatment targets. And it's easy to manage the patients, and it's not for cardiologists, it's mostly for primary care physicians as well, just to manage the patients easily and according to clinical guidelines, and also increase the KPIs, what I mentioned in the as a cardiometabolic, and we can prepare this for uh, any healthcare providers, public or private sector. Yeah, and I think we can if we have some questions from audience, we're more than happy to answer regarding the cardiometabolic patient management quality AI using. If someone have a question, just raise the hand, and we switch on mic, and more than happy to answer. I will check the question and answers. So right now we don't have any questions. Yeah, please, Ryan, go ahead.
Yeah, maybe I just have a question like, so the foundational models that you're using, can you just give us an idea about what are the foundational AI models that you use in your solution?
Yeah. In this case, we use large language models as an interface. We don't use it for check the data or something like this. And also, when we extract the data, sometimes it's unstructured and structured, and we also use the large language model to stratify and structure the text data and put the right message for clinical profile of the patients. And for the answers come from the large language models. We can use it on premise. It's open source models, and we can use it on premise and manage very easily within the healthcare IT infrastructure.
Yeah.
Yeah, Dr.
And those,
Summer.
sorry,
Yeah. Okay. Please, Rami,
should I go ahead?
add
Yeah.
something. Yeah.
No, so those use cases that you showed, like you mentioned earlier, obviously they address it's almost like a population health approach. So who are the end users who you target, or who's your audience basically?
Yeah, it's a quality manager. Also, it may be a medical director who can analyze on the healthcare provider level and also manage the list patient for group of clinician who can manage it through the telemedicine or through the patients follow-up, because right now telemedicine reimbursable and it's easy to use this tool as well. It's save time and make best quality of the management of chronic disease patients.
Great.
Hani, do you have any questions regarding because sometimes usually clinicians spoke about patients without patients, but right now you as sometimes patients with chronic disease became a clinicians as well, and he can discuss on the same level because you have terminology, you know the medicine names and so on so on. What is your message and comment from patient voice?
Well, thank you again, first of all, for involving me in this, Dennis, and having me in here. That is really something that I am proud of. And it's my honor to be in here between you guys to present how the patient feels and how's their experience. And honestly, really, would love to see the AI goes up to the level of helping the physicians and the cardiologists to early detect the symptoms and save many lives as early as possible. From my side, from my own experience, I keep thinking of the root cause of this. And I keep thinking, and that's probably a question for the panelists too, having diabetes, psoriasis, and now definitely I am 100% cardiovascular disease holder. So those all correlate with each other. And I'm thinking, when do you think the AI system could support an early detection through a blood analysis of the interleukins to identify those symptoms as early as possible?
Yeah, I think it's a very, very good question. Dr. Samer, do you have
Okay. Right. So we'll go, you and I, Hani, to China. We'll go 2600 BC. We open a book that's very old, and it says, mediocre doctors treat the disease. Reasonable doctor, I forgot the word they said, treat the disease before it happens. Outstanding doctors, whatever the word is, that prevent the disease. So then we come back 5,000 years from then. So for years, we've known that prevention is very important. Before we go into interleukin and some theories, etc., the fact that you can check your sugar at all times, and I've written an article on this in the Emerge of Medicine around 4 years ago. When I wrote the article, I was told that this is not real. And now it's a routine to have the sugar checked by any means. There are now blood pressure gadgets that are non-inflatable. At least four of them are currently, at least, there's nothing called approved. They are cleared by the FDA. There are many other things, but Hani, really, the idea is not the interleukin that may be suggestive of inflammation. And this is very common in psoriasis patient. But the idea behind this is to go back to the basics. I'm just telling you this now, and I say it to everyone, to me, to you, to everyone. We all know what needs to be done in a way. We don't know to what extent, yani I'll give you an idea. We all know the blood pressure needs to be normal, but what is normal? Less than 130/80 for you. We all know the LDL needs to be lower, the better, but for you, needs to be less than 1.4. I'm sure you heard that. We all know the hemoglobin A1C should be less than 7, at least in most people. The trouble is how to get there. I think personally, 95% is 101 medicine, AI, and 5% is what you're talking about. the breath test, and the prediction, etc., etc. I'm sure you know, Hani and others, that now through the retina, I can tell who's going to have dementia in the next 6 years. Through a chest X-ray, I can tell what the thyroid function test is likely to be, which is ridiculous. And this is from nature. But that's not going to change much. What's going to change much is from the data we have to have a clinical supports decision system. And I'll just call it a CSCD that tells me in this case, insist on this. And Hani, the material that is given currently to the patient is very limited. The follow-up is very limited. Please let me take a second and focus on my friend Hani. Imagine that you see me and Rami twice or 3 times per year. What kind of medicine is this? 3 times. You see us for half an hour if you're lucky. So 1.5 hours. Hani, can you do the math with Rami, please? Divided by 365 days. It's a joke. So basically, the doctor is you. And if we can, and this is not falsafa, it's real. If we can say nothing about me without me. So healthcare is keep me safe, safety, heal me, evidence-based medicine, be nice to me, patient experience, and engage me. Healthcare will be transformed through 2 engagements. Engagement of the physician with the guidelines and engagement of the patient in implementing the guidelines. That is really the model that will transform healthcare within 5 years from where it is now, because not where it should be. Now it is called sick care, not healthcare.
Yeah, and also like as you mentioned, like for example, not all clinicians know that atorvastatin in high dosage increase the glucose, but in the instruction of this medicine, it's mentioned that please be careful with diabetic patients in high intensity dosage because it can lead to the increase in the blood sugar.
So
And
the algorithm then is
it's not a guidelines. It's instruction for any medicine. And for medicine, we also need to know all these medicine. Like you use 5 or 6 medicine per day, but we need to know very deeply each medicine, how it works in your body, in your system with psoriasis. For example, like bisoprolol, he has this medicine also can lead to the psoriasis activity. It's mentioned in the indication in the instruction. You can watch it, and maybe like in this scenario, maybe you need to change for another beta blockers.
If you
Yeah,
allow me 1 second, Dennis, there was a patient in my clinic that was taking 7 medications. I asked several cardiologists, they said there's no interaction, unusual medication. When I showed them through a simple chat GPT without obviously mentioning the name of the patient, there were tons of data on negative interaction and positive. The danger of the atorvastatin is not 200 to 300, 1 in 200, 300 of slight increase in hemoglobin A1C. The danger is people will stop it altogether. So unless this was an education and unless we followed the hemoglobin A1C and a small subgroup will go up, and again, we don't want to be technical about this, but I'm just bringing this up, then the danger is not even the hemoglobin A1C as much as the patient would stop right away. And then they will never take this. So hopefully what we're trying to discuss is that simplifying things is more likely to lead to success. And you know, you know the story, right? If you understand it, you can simplify it. And more importantly, simplifying healthcare, not sick care, for the patient and for the doctor should be a goal while maintaining efficiency, quality, and good outcome in a model that engages the patient and is supported by governments and regulator, and also with the governance that Dr. Rami spoke about. Without governance, this is failing from the beginning. That's all what I have to say. Thank you.
yeah, and I think we have a last question. Like, is it this solution implemented in UAE or in the GC region? Right now, we on the process of proof of concept with some private and public sector hospitals in UAE and also in Oman. And I believe in 1 month or maybe 2 months, we show the results not from our Russian-based experience, because this solution was implemented successfully back in Russia and save a lot of time of physician and outcomes of patients. And I believe as soon as possible, we implement this solution and AI in clinical practice in the region. And thank you very much for your engagement, Dr. Samer, Dr. Rami, Hani. Thank you very much. Yeah, we'll be get in touch regarding your targets control. And yeah, I think we can nice spoke and discuss, and we can close this discussion right now. Thank you very much.
Thank you, everyone.
Thank you very much.
Thank you.
Bye-bye.